Opposition to labor and Nigeria was rampant then, but I want to tell you that it still exists today. And as a statement of fact, the lumbar epidural block is considered the gold standard for intraparty analgesia. We designed this study to ascertain the level of awareness and acceptance of labor analgesia among the pregnant women coming attending the antenatal clinic. The aim is to see if we can initiate labor analgesia services in the teaching hospital. This study was a cross-sectional study conducted among pregnant women attending our antenatal clinic where the age of questionnaires, who are those that admitted the questionnaires, doctors, nurses, students, all the other people who couldn't read were being assisted, those who were allowed to fill by themselves. Of course, the questionnaire contained demographics and other pertinent items. And data collected were analyzed using the SPSS version for using simple statistics. Result. The summary of the result. A total of 275 respondents were recruited within a period of 4 months. And the age range 25 to 29 was the highest with an average age of 29.84 with a standard deviation of 4.52 years. 56% had no awareness at all, and 7.5% would accept. So we are comparing awareness, we also compare acceptance. And the commonest reason given for acceptance was the patient would enjoy pain-free labor. While the commonest reason for rejecting was that labor was a natural process and should not be interfered. Though they will not accept. All the respondents, of course, were female within the reproductive age with the average I just told you. Of course, this place in my body, and it's not surprising that the team ethnic group, 1.3%, were in the majority, followed by Idoma Sadigedes. And then, of course, 95.6% were Christians, understandably so, because Bene is predominantly Christian. And then, of course, because Bene is blessed with a lot of higher institutions, it's amazing that among those who came to be those that were recruited, 84.4% of them had higher institutions. So they took advantage of the many higher institutions in Benue State, and our women, I can proudly say, are quite educated. Of course, 86.2% were not aware at all. Barely 13.8 are those who are very much aware or had enough awareness. So if you look at those who are very much aware and enough awareness, we are just 13.8%. So this result is in tandem with similar results in other developing countries. The problem in this situation is compounded by a dearth of trained manpower too. Because if we are available, like what I've started, how long have I been there? Somebody just joined me. Sadly, as of today, Dr. Osho just joined, and we have 2 consultants and histologists the whole of Benue State. So if we're not there to even talk to people, how will they even know that this can take place? So, but in developed countries, because labor analgesia is easily available and accessible, the issue is focused on the choice of methods and complications. While in developing countries like ours, the issue revolves around awareness, number 1, acceptability, and even when they accept, how available will it be? So our result is less than what to say nationally. I'm happy that at least nationally, it's 13.8%, falls short of 27%. And in Lagos, that has, from the literature I was able to access, had the highest, 13.9. I don't know if somebody has done one in Abuja. Maybe it should be more. You know the reason? There are more people here and there are more people going about. When I was in National Hospital, there are a lot of advocating. I don't know, maybe Abuja might compare to Australia, because in Australia, awareness is up to 98%. The most frequent reason given by response for accepting labor is that it will make them pay free. So that then of course 50% say they will not believe that labor was a natural process. It is important too to know that some people, up to 24.2%, well, they believe that labor in Nigeria could be harmful to their babies. If I should observe that discrepancy in the level of awareness and acceptance they were able to unearth could be attributed to the fact that childbirth is still viewed as a physiological process in most of the developing countries, which is managed with as little interference as possible. Many women still do not know that pain of labor can actually be taken care of during labor. We correlated the awareness and possible assistance of labor and Nigeria. 100% of those who profess good knowledge say they will accept, not rejected. The out of those who say they had enough knowledge, 87 were able to agree that they will have labor. But those who had no knowledge of labor and Nigeria, surprisingly, 80% of them said they would accept. The important is that the 20% that rejected accepted constitute the 50% of those, the total percent of the respondents who rejected labor and Nigeria. We believe that a relationship has been established between awareness and acceptance. The more aware they are, the more likely they will accept labor and Nigeria when offered. So in conclusion, awareness for labor and Nigeria is quite low amongst pregnant women attending our antenatal clinic in our institution. On the other hand, the level of acceptance is high. However, this study revealed that the higher the level of awareness, the more likely they are to accept labor and Nigeria if offered. It is safe to conclude, therefore, that there is a high level of acceptability among our clients at BHG. But for the purpose of establishing labor and Nigeria services, there will be drawbacks because we don't have enough manpower. I am the only one in the Benue State University Teaching Hospital. Dr. Shio is the one at the Federal Medical Center. And manpower is low. The last time we bought thank you. The last time we tried labor, so it's the high cost. Thank you. More training, more this is if Saudi Arabia will allow us to deploy more.
Thank you very much. The next presenter, please, Bubu Yakubu Mohammed.
Good morning, everyone. I am Dr. Ugu Euphemia from Ahmadu Bello University Teaching Hospital. I am here to present the effect of intravenous dexamethasone on the duration of epidural labor and anesthesia when bupivacaine and fentanyl is used. I am the main author, and I have others, Yakubu Wsfa, Mohammed Arai, Tasio S, and Professor Ogolimwaso. Under the following, it's going to be presented under the following outline. Labor pain is the worst pain any woman will ever experience in her lifetime. Is a very excruciating pain that every woman will want to actually avoid. Among the most severe pain that's only surpassed by the pain of digital amputation. Labor pain leads to, it has a lot of negative effect on the woman. It leads to maternal distress stress, intense fatigue, and also other undesirable effects on the cardiorespiratory physiology of the woman. It causes raise in release of catecholamines, which will lead to increase in cardiac output, and also contraction. Contraction also displaces about 250 to 300 ml of blood from the uterus into the central circulation, also thereby leading to rise in cardiac output. And this can have deleterious effect on parturients that have significant cardiac morbidity. Effective analgesia will reduce this undesirable effect of contraction, catecholamine release, and also attenuate the negative effect of the release of this stress hormone. American Society of Anesthesiologists and American College of Obs and Gynae state that there is no other circumstances where it is considered acceptable for an individual to experience untreated severe pain amenable to safe intervention while under the care of a physician. Also, National Institute of Clinical Guidelines also recommended that a woman that is in labor should be given option of available labor analgesia. Labor analgesia started with James Young Simpson when he administered ether to a woman with pelvic in labor with pelvic deformity. Although this was actually condemned them by critics who believe that labor pain is a punishment that was passed down from Eve to her descendant, and they believe that women should accept it as it is ordained by God, that they should serve that punishment. Okay, thank you. So, but now some also believe that it should be amenable, and science and technology has also proved that. There are several methods of labor analgesia. We have the pharmacological and the non-pharmacological method. The pharmacological method, which include use of inhalational anesthetic, systemic opioid, and regional analgesia. Also, the use of paracetamol. There are multiple randomized trials that have demonstrated that there's lower maternal pain scores and higher satisfaction with regional analgesia. And still yet, parental opioid is what is used mainly in our environment, which has been proven to have some harmful effects both to the uterus, to the fetus and the mother, because it usually lead to maternal respiratory and fetal respiratory depression. The local anesthetic and opioid are used for labor analgesia, and it has proven to have a favorable result. Neurasia adjuncts increasing the efficacy, quality, and prolong the duration of action of the local anesthetic agents. The dexamethasone that is used in this study is a glucocorticoid with anti-inflammatory property and minimal mineralocorticoid activity. There are a lot of controversies surrounding it because of the standard dose and the safety of its use intrathecally, because it contains a preservative. So several studies have demonstrated that a single dose of intravenous dexamethasone is associated with less post-op pain and less post-operative opioid consumption. There is a positive, although it is safe, effective, and inexpensive choice to reduce post-operative pain when given shortly before surgery, but there is the positives of its intrapartum use, and this is what better the need for this study. The aim is that this study evaluated the effect of single dose intravenous 8 mg dexamethasone on the duration of epidural labor analgesia using 0.125 mg of bupivacaine and 2 microgram per ml of fentanyl. The method, institution ethical approval and written consent were obtained from the partner. 56 pregnant women that met inclusion criteria were randomly assigned into two groups, 28 partners per group. Group A received the IV intravenous infusion of 8 mg dexamethasone in 50 ml of normal saline and 50 ml of normal saline respectively in both groups. After 30 minutes, catheter-based epidural labor analgesia was now established. All participants received the initial dose of 10 ml of the studied of 10 ml of 0.125% of plain bupivacaine premixed with 20 microgram of fentanyl, and there's a background infusion at a rate of 5 ml per hour, and a demand bolus of 5 ml of the same concentration if it is needed, with a lockout interval of 30 minutes. Then the labor pain intensity was assessed with visual analog scale. The time to first analgesia request was determined, and a p-value of less than 0.05 was considered to be statistically significant. There was the result. There was prolonged time interval between the administration of intravenous dexamethasone and the first demand bolus of analgesia in the partners that received dexamethasone. However, the difference was not statistically significant, as the average time of the first analgesia request in minutes was 166.3 with the standard deviation of 89.9 minutes compared to 158.6 with a p-value of 0.7. This is the.
Thank you very much. Next presenter, please. Dr. Anthony. All presenters, remember you have 8 minutes. Thank you.
I'll introduce myself like to come up. Well, good morning, everyone. It's lovely to be here with you all today. My name is Juliet Antonet, and I am an anesthetics registrar based in the UK. And today I have 8 minutes to share a case with you that I was personally involved in that had, unfortunately, its bad ending. However, there's quite a few learning points that I've taken away that I'd like to share with you today. So the plan is to very quickly run through the case and to mention my 3 main points that will help make future practice and hopefully will help you too. So I'll just get into it. So this patient was a 40-year-old lady, and this was her first pregnancy, but unfortunately at 10 weeks pregnant, she miscarried. She was offered various management options and she chose to have surgical management. And she was booked into the elective list to have this done. In way of medical history, she was actually a relatively fit and well young lady. She did have a diagnosis of neurofibromatosis type 1, but this didn't really have any major effect on her. I mean, about 10 years ago, she had a removal of a spinal lesion under general anesthetics, which was uneventful. In her medical history, she did mention that she sometimes suffers with low blood pressure and dizziness. but it was nothing that the GP was particularly concerned about. Her BMI was a touch bit low, but nothing too worrying. As I said, she was a fit lady that exercised, etc. So as I said, she was booked onto the elective list. I was the anesthetist on the day, running my solo elective gynae list. I discussed her with the overseeing consultant, and again, she wasn't very interested. This is a fit and well young lady having a simple procedure. I'm a Gen-Z anesthetist, so she had TIVA anesthetics, which I love. And as you can see from the chart, it was a pretty boring anesthetics, which is what we like to see, and uneventful. So she finished having surgery okay, went to recovery, she was absolutely fine, and actually got home that day with no problems at all, until the next day. So the next day she was brought in via ambulance, and she was complaining of abdominal pain, chest pain, and some shortness of breath. She looked quite unwell actually. In the ambulance, as you can see, she was quite tachypnic with a poor SATS trace, tachycardic, hypertensive. When she came into ED, she pretty much looked the same, remained tachypnic. The blood pressure had come down a little bit, so she was now 119/98, but she was also noted to be just quite dry, cold, mottled, and just shut down peripherally. She had a VBG done at the time, which showed she was acidotic. I didn't get the lactate in the documentation, but a verbal report to me was that it was primarily metabolic acidosis. So at this point, everyone is wondering what on earth is going on. This is a young, fit and well lady, simple operation. However, she did just have an operation. So the main diagnosis on everyone's mind at the time was peripulmonary embolism. So because she looked quite unwell, ED's plan was to get ITU down to escort her to have a quick scan. They did give her some IV fluids. However, she deteriorated quite quickly and arrested before she could get to the scanner. So the cardiac arrest was a